All right, so reproduction. I picked this guy as our mascot. You all know who he is? Mr. Bean. Yeah. Okay. We'll start questioning about his sexuality. But anyway, so the way I'm doing reproduction is this. This is the preview and how I'm organizing it all. All right. We're going to do today the female anatomy. We'll try and knock that off. And also breast anatomy and physiology. That's a fairly short thing, but there is some hormones that we've got to talk about there, prolactin and oxytocin. We'll deal with that afterwards, or a little bit later. Menstrual cycle, we'll save that for another day. And then we'll do the male anatomy and physiology. The male physiology, there's not much there. Anatomy, there's a little bit more, and I kind of put together with sexual differentiation. Because up until about 5 weeks after the egg and sperm unite, you can't tell if it's a male or female. There's another hormone that comes in, and the gonads start, the genitalia starts changing, and then you can see things. So we'll talk about sexual differentiation. Then we'll spend some time talking about pregnancy and development. It's the last chapter in your book. And then we'll get into, very briefly, some important medical statistics I want you to know. The killers in America, things like that. And that's, there's only like 5 slides on that. But it really wraps together what you've been learning in A&P 1 and 2. All right? So that's basically how I kind of broke this whole down in this one PowerPoint. All right, so obstetrics and gynecology. Basically, the obstetrics is really just pertaining to the pregnancy and childbirth. Gynecology is really pertaining to women's studies itself, and we refer to it as OB/GYN. So you could be just an obstetrician, you could just be a gynecologist, but most people will pick both, or they're going to subspecialize into other things. I'm not going to test you on that, but since I'm a gynecologist, obstetrician, we're talking about that, just so you have that cleared over here. All right, so let's talk about female anatomy. The vulva, another word for vulva is basically the external genitalia. And the vulva incorporates a few different things. There's the mons pubis, which is the rounded fleshy area pad, and this has the pubic hair on it. Let me, it's probably easier if I just show you the picture and we'll just label things, okay? So the mons pubis is up here, okay? This, of course, is the vagina. The vagina itself, the entrance to the vagina is called the introitus. Now, this is actually spelled wrong. This is how you spell it. Introitus with an R in there, okay? And here they're saying it's the vaginal introitus. It's not like we're from New Jersey, right? So it's that kind of thing. But it's introitus. And basically, it's just the entrance to the vagina. Now, a few things on here. The mons pubis, which is the area that has the pubic hair, goes on either side of the vagina. So it kind of just extends downward. Still the pubic area, so the fleshy pad over here, that's called the labia majora on either side. That's the part that still has pubic hair. As we get more medially, there's also going to be fleshy areas here, very thin. Those are called the labia minora, and that does not have the pubic hair on it. Okay? Now, going from anterior to posterior, this is where students do get mixed up with certain things. We're going to have the clitoris there, and the clitoris is a highly sensitive area for sexual arousal. The next part is the meatus to the urethra. Meatus is just a fancy word for opening. And then we have the vagina, or the introitus to the vagina. We then have this area here called the perineum, which is a fleshy area here between the vagina and finally the anus. You should know these orders, going from anterior to posterior, posterior to anterior. I find that students get mostly mixed up between the clitoris and the urethra. A lot of them think that the urethra is more anterior than the clitoris. It's not, and even finding that female students are having the same confusion. But this is important when you become a nurse or you're going to be doing something with a catheter that needs to go through the urethra going into the urinary bladder. You need to make sure you know the difference between these two. Because if you take that, and a catheter is like a very thick rubber band, about maybe a third of an inch or so. quarter inch. And you got to put that, and you have to put it into the urethra, right? The meatus, the opening to the urethra. If you don't know where that is, you start jabbing it at the clitoris, I guarantee that woman will never let you touch her again. All right? Because it's highly sensitive there. You need to know anatomy and make the female as comfortable as you can. All right? So you need to know what's anterior and what's posterior. Okay? And I'm saying this because also a lot of women that we have to do this with, their legs, the inner thighs, have a lot of adipose tissue there. So this actually is all covered, or they don't want to spread the legs so that we can get the catheter in there. So you've got to visualize this. This will all obscure your visualization. And most of you who are going to the nursing program is going to have to do this. All right? So you should know those. All right? Questions about at least the vulva and the parts of the vulva? Okay. Now there's other things that's now a little bit more deep. We have things called the bus glands. They're really called the Bartholin's glands, the urethral glands, and Skene's glands. These are all glands that are found, let me get back to this. The openings of the glands are all found right around here, just medial to the labia minora. The openings there are going to release, or it's going to secrete a mucus for sexual arousal, so that the penis can actually be inserted without any kind of struggle into the vagina. Okay? The reason why I mention these also is that these can also pertain, or these glands over here can also become inflamed due to infections. So if you ever heard of a Bartholin's cyst or a Bartholin's abscess, that's where it's infected, and they have to. Sometimes these will get so big that it would obstruct the introitus. So they need to incise it, open it, and let everything come out. And we do other things too to remove. We either put something called a Word's catheter, or we might have to just we'll have to fix it up. Okay, but those can get very painful too. Okay. And then the perineum, like I said, is that tissue, that skin between the vagina and the anus. Now, let's look inside the female anatomy. I kind of say it looks like the Dodge Ram. I'm wondering if that's where the Dodge Ram got its idea from, right? So let's go through this. And everything I'm going to explain is on the next few slides in words, but I just want to show you what's going on here. Here's the vagina. This is the uterus, layman called the womb, which is going to hold the pregnancy, all right, the baby. The opening to the womb, the doorway, this is called the cervix. The area of the vagina that's surrounding the cervix is called the fornix. So you have lateral fornixes, you've got an anterior fornix, and you've got a posterior fornix. You have two fallopian tubes. At the end, they have these little finger-like projections. They're called fimbriae. And then you got your ovaries over here that is going to have all the eggs. There's a few layers you need to know about the uterus. There's an outer layer, a visceral layer, called the perimetrium, that kind of just connective tissue to hold the whole thing together. Then you've got a pretty thick muscular layer here that's going to give you those wonderful contractions, smooth muscle. That's called the myometrium. And then you're also going to have this inner lining of the intrauterine cavity, and that's called the endometrium. The endometrium is important for two things. One, that's where the implantation of the embryo is going to go, is in the endometrium. It goes into the endometrium. It does not go into the myometrium, the muscle. If it does, and it does in a certain condition called placenta creta, but you won't have to worry about that. It needs to go in here. If it goes into here, it's going to be virtually impossible to get out the placenta when you deliver the baby. And usually, unfortunately, women would lose their whole uterus because of that condition. Luckily, it's very rare. So the embryo needs to go into the endometrium. And the other thing about the endometrium is that's the part that sheds each month during a menstrual cycle. All right, and we'll get into that next week. But a menstrual cycle, it removes this area here, the endometrium, and blood follows right afterwards because then it's going to be very raw there. So menstrual cycle isn't about the bleeding. That's the aftermath. The menstrual cycle is about removing the endometrium so that we can put a nice clean endometrium right afterwards. It's just that blood follows right after that endometrium comes out. Okay? What happens with the egg, when the egg ovulates, all right, the egg is also known as an ovum. When the egg pops out of here, it's called ovulation, and it goes right directly into the pelvic cavity. Luckily, these finger-like projections kind of create like a vacuum. They move. And as they move, when the egg pops out of here, it feels the vacuum and gets sucked up into here. Okay? The egg will follow this way, sperm goes this way, and it usually unites in the fallopian tube, right where the bend is. Then about another 4 or 5 days, the fertilized egg will come here and implant in the endometrium. Okay? That's just a very overview-ish of this. We'll go into the details of it later. Now, some other things. There's something called a broad ligament. And this is just connective tissue that's going to go over this whole thing. Over the uterus, over the fallopian tubes. It's just going to cover over all this and holds the female internal organs in place in the pelvic cavity. Okay? The adnexa is a fancy word for fallopian tubes and ovary. Collectively, they're known as the adnexa. Okay? So if someone has an adnexal mass, that's what they're talking about. The vagina is about 3 to 4 inches long. And like I said, the fornix is the vaginal portion that's going to surround the cervix. Okay? So this is just showing again. All right? The broad ligament has different parts. I won't ask you about these different parts, but the broad ligament is this ligament. You can see this white, this beige area around here kind of covers the whole thing. All right? It's just right on top of the uterus and stuff like this, but it's just going to cover all this. All right? It should be on both sides, but it's just doing it for a diagram. I do want to also make note of this, and I'll get back to it, that this here, the ovary, is not connected to the fallopian tube. I mean, they may be touching, but they're not connected. The fallopian tube is definitely connected to the uterus. You see that. But these are not connected. And that's why I'm trying to emphasize to you that the egg goes to the pelvic cavity first and needs to be vacuumed in to here. This also makes point of how diseases might occur. If there's a sexually transmitted disease that occurs here, let's say gonorrhea or chlamydia, and attacks the cervix, it can easily ascend up through here, go through the fallopian tubes, and goes out and can go to your liver. Because the abdominal and pelvic cavities do not have a physical barrier. In a male, it is a closed system. In a female, it's not a closed system. And you need to understand that too. Sexually transmitted diseases in a female can get into the abdominal cavity, and there's many cases it goes to the liver. And I think you all know that we don't want the liver to be compromised. There's so many functions that it does. Okay? So just emphasize that they're not connected. They're touching each other, but they're not connected. Okay? All right, so about the uterus. It's about 3 inches long. So we're looking at maybe the size of a small peach. okay, about that size, in a non-pregnant uterus, of course. And just showing you over here, here's the pubic symphysis, here's the woman's belly, so her belly button's up here. So you're doing a sagittal cut of the woman's belly. Does that make sense? Here's her bum, and here's her belly button, right? So the pubic symphysis is here. Here's her uterus. I'm sorry, let me say it again. Here's the pubic symphysis. Here's the urinary bladder. And posterior directly, let me say it again. Pubic symphysis, urinary bladder. The organ directly posterior to the urinary bladder is going to be the uterus. And then behind that is going to be the rectum. If this is the urinary bladder, there's the urethra. The vagina is over here and the anus is over here. Okay? Now, in most women, about 75% of women, this uterus is tilted forward. When it is, we refer to as anti-flexed. Okay? In 25% of women, it's bent backwards. It's bent like this. Does that mean anything? No. But we have a room of 20 women in here, 5 of them will have a uterus that's bent backwards. What makes it a little bit interesting about this is that, not really interesting, but if a baby forms in here, this is going to kick this way and move up that way. If a baby forms in here, it kicks this way and goes that way. So bending forward or bending backwards doesn't mean anything. It's still going to develop a baby without any kind of compromise. The only thing that might cause problems, or really not problems, but an uncomfortability, is when a doctor is doing an examination on a woman if the uterus is bent backwards, or what we call retroflex. Because the doctor needs to get 2 fingers behind, or in the posterior fornix of the cervix, and lift up. So basically what they're doing is called a bimanual examination. If I put 1 finger behind a cervix here and another one on top, so when a doctor's doing an examination, there's one in the vagina and there's one on the belly. And we're trying to estimate the size of the uterus. It's like if I'm not looking at this tabletop and one hand is behind it or underneath it and one is on top, I have an idea by the way my hands are positioned that I have an idea of how far my fingers would be between each other. And I can come out and say, yeah, it's about that thick. You see what I mean? So that's what we call a bimanual examination. In a woman who has, let's say, a retroflexed uterus, the doctor's fingers have to go deeper into the vagina to lift up the uterus. So it can get very uncomfortable. So I'm saying this to women in this room, or let's say your own daughters or whichever, if the doctor says to you, oh, sorry about the uncomfortability, but you have a uterus that's bent backwards, that's what he or she is talking about. It's not going to cause any diseases, is what I'm saying. Oh my God, I got a uterus that's bent backwards. I got to worry about. No, you don't have to worry about disease. It's just a little bit more of a, I guess, a struggle to do the examination itself. Does that make sense? Okay. And the only way you can understand it is knowing anatomy, which is this course. That's why I wanted to tell you about the variants. All right. So anyway. Again, the top of the uterus is known as the fundus. The body of the humerus, the biggest part, is called the corpus. All right, and then the intrauterine cavity, the lining of it is the endometrium, and again, that's the part that sheds off during menstruation. That's the part where the embryo gets implanted. The myometrium is the muscular layer that's going to give you those whopping contractions from good old oxytocin from the posterior pituitary gland. Okay. And the perimetrium is the outer visceral layer that's going to cover things. All right. In this case, it is the broad ligament. Right. It's the broad ligament and this perimetrium. If it's on the uterus itself, it's the same thing. Okay.
I will. I'll just have to go with you.
So this is just showing you in perspective with the pelvic, with the pelvis itself, how the uterus will lie in at least 75% of women. All right. It's bent forward. There's the fallopian tubes, and there's the ovaries. Okay. Now, if we get up closer to the uterus, we're going to see a few different things. And this is trying to get you organized a little bit of how this is set up before we get into the menstrual cycle. This is the intrauterine cavity, the lumen of the uterus. Here's the endometrium. The endometrium is this gray layer here. Here's the myometrium, the thick muscular layer. And the perimetrium is the outer area, very thin layer over here. So this is what's going to happen. When the gray area is going to shed off, the endometrium, that's going to leave open blood vessels there, and that will cause bleeding. So then we have to go through another cycle. So now what it does, and we're going to get into those later, then these blood vessels will start forming smaller blood vessels. Now smaller blood vessels start off as like a treacherous kind. They kind of, they don't just grow straight out like this, if this is where the original blood vessel is. If this is the original blood vessel, they kind of go like this and then eventually straighten out. So because of this, we call these blood vessels spiral arteries, because they're young arteries, so to say, that are just forming. We're going to be using those terms later on. Okay? So that's what you're seeing here, is these spiral arteries over here. The cervix is the opening to the womb again. And this is a close-up of it. You'll see here, this is the vagina, and you can see the rugae in the vagina. Again, whenever you see rugae, that should tell you something that's going to stretch, right? We've seen it in the urinary bladder, we saw it in the stomach. It's telling you something, right? Again, physiology reflects anatomy, right? Function reflects structure. You see rugae there, you already have an idea of what the function is. So this is the vagina here, and here is the cervix. Kind of close up to that, okay? Let me just talk a little bit about cervical dysplasia, and then I'll let you guys go, all right? Cervical dysplasia. They're abnormal cells that grow at the cervix, and these can lead to cancer. They may also be due to an infection. So this is what a pap smear is all about. You've heard of people having pap smears, if not yourself, right? The original name was something called Papa-Nicolau smear, all right? It was made, I think it was a gynecologist back in the 1950s. His last name was Papa-Nicolau. Interesting fact, all right, when I ask you about this. When I was in England, I would say, okay, we're going to be doing a pap smear. They had no idea what I was talking about. I said, well, we call it Papa-Nicolau. They know it as a Papa-Nicolau smear. Here in America, we know it as a pap smear. Go figure, okay? But anyway, that's what that is. And what it is that they're going to put a speculum in, and that's the part that they insert into the vagina so they can visualize the vagina and the cervix. So they put the speculum in there, and then they're going to take some scrapings off of the cervix. And then it's sent off to lab. So what it is that this is that speculum. It's either a clear one like this, plastic, or a metal one over here. So here's where the speculum goes in. So again, it's going through the vagina. Here's the uterus. So it doesn't go into the uterus, it just goes into the vagina, and you can actually see the side walls of the vagina itself, and you can see the cervix. The cervix, this is what the doctor sees. This little opening, because that's where all the sperm goes in, that's where the baby comes out, believe it or not. That thing opens up to 10 centimeters, which is about, I guess, 4 to 5 inches, right? But that little opening is where the baby's coming out of, all right? And we would see if there's anything on there. What we're going to do, that's what a normal cervix will look like, the opening will look like. It has a little reddish over there, and that's what the doctor would end up seeing. And what we'd do is we would take a speculum and go round 360 that way and round 360 that way, put it on a microscope slide, nurse would spray it with a fixative, and then we would need to get some tissue inside too. Not all the way, it's a very small thing, only like a centimeter, maybe like a half an inch. And then we just do a little brush, we go in, swirl it one way, swirl it the other way, and then smear that on a microscope slide. What I'm saying is a pap smear should only take 10 seconds to do. that make sense? That's all we're doing in there, and we're actually visualizing stuff as we do this. This is what cervical dysplasia looks like, where you see the pink is all normal, but you're seeing all this red here. That's all. If I see something like that, I know there's something going on. Is it cancer? I don't know. Is it something before cancer? It could be. It could be an infection. But that's what this pap smear is going to do. It's going to screen to see what it is. And sometimes it's not this discrete. Sometimes it's so minute that you can't even see it with the naked eye. That's why you still got to do a pap smear to see if you get the minor stuff and send it off. Okay? Now let's talk to you about fallopian tubes. The fallopian tubes are two tubes that extend off the lateral sides of the uterus. They're about 5 inches long, and it's about as thick as straws, right? Not one of those stir rods you get at Starbucks, but like a McDonald's kind of straw, like that. Fallopian tubes are also known as the oviducts. Okay. Again, medially they're connected to the uterus. Laterally, they're not connected to anything. They're touching the ovaries, but they're not connected in a way that the uterus is over there. Okay. Now, there's different parts of the fallopian tubes you need to recognize. Okay. The lumen of the fallopian tube, all right, is lined with simple columnar epithelium, but this is a special kind because it has cilia on it. The cilia is there to actually, when the egg goes into the fallopian tube, the cilia kind of push it towards the uterus and says, go ahead, go meet the young guy, he's okay, keep putting, and they push him, okay? So that's what the cilia does. Now, smoking, as you've seen, smoking affects all kinds of cilia, including the trachea, right? So it starts slowing down the movement of the cilia in the trachea, and that's why smokers have that big, what we call the smoker's cough, because usually cilia is going to push all that mucus so you can cough it away. But when smokers smoke a lot, the cilia and the trachea aren't moving that fast. So then the mucus stays in that area. That's why they always have a productive cough. Well, not only does the cilia get affected in the trachea, but the cilia can also get affected in the fallopian tubes, and they won't move. So yes, smoking can lead to infertility because it doesn't push the egg towards the sperm. Okay? Now, as much as I said with that, the guys also have flagella on their sperm. And the flagella is just a very long form of a cilia. So yes, smokers for males, it can also cause sperm for not being motile. So smoking is a risk factor for infertility for both men and women. Okay? And peristalsis is going to move it also there too. Now we have different parts of the fallopian tube. The one that's closest to the part that's closest to the uterus is called the isthmus. Then you have the ampulla, which is the majority of the fallopian tube, and it's the part that has the biggest bend to it. That's called the ampulla. This is the site where fertilization takes place. This is where the sperm and the egg unite, is at the ampulla. You should know that one, okay? Then it's going to funnel out, and that's called the infundibulum. And at the end of the infundibulum have these finger-like projections, and they're called fimbriae. The fimbriae are going to they're going to move. They're bigger than cilia, and they have a different mechanism than the way cilia works. But they kind of move very slowly, but they create almost like a vacuum so that the egg, when it pops out of the ovary, it kind of goes into the fallopian tube. So this is the whole thing. There's the fallopian tube. There's the isthmus. This bigger portion is going to be the ampulla. This is where fertilization takes place. It funnels out to be called the infundibulum until we get to the fimbriae, which are the finger-like projections. Okay? Questions about the fallopian tube? Pretty straightforward. All right, now we got the ovaries. And the ovaries they're about 2 inches in diameter. Okay, they're about oval. They look like an olive, about the size of an olive. And it stays about that size until you're about 50 years old, and it starts gradually shrinking to become the olive pit. And I'm talking about the size, not the literary sense, okay? But it turns into something very small. The ovary is going to hold all the eggs, all right? They're called ova. So we have these follicles, which are basically the egg sacs that are holding up the eggs, and they're in there. Now, the eggs are also called the ovum or many ova. Okay, one egg, many eggs, one ovum, many ova, or they're also called oocytes, not oocytes. Okay. A woman is born with 4 million eggs, but only about 400 ever get ovulated in her lifetime. You should have two questions now. First, how did I come up with 400? And two, 4 million eggs and now you got only 400? What happened to all the other ones? Right? Those are the questions that are in your head right now. So let me first knock off for you the reason how I came up with 400. And I'm going to make the math a little bit easier for you guys. Let's say the first time a girl ovulates is at 10 years old. Okay? And the last time she ovulates is going to be 50 years old. Easy math. Now, assuming that this woman, girl, never got pregnant, meaning that when you're pregnant, then 9 months you're not going to ovulate. And the average woman has 2 children, so it's 18 months in her life, they're not going to ovulate. But we're assuming that this girl never got pregnant, and she never was on birth control. Birth control actually stops you from ovulating. So that means that how many times a year throughout her lifetime did she ovulate? 12. All right? So there's 12 years. Well, how many years is this? 40. And then she ovulates 12 times, comes to 480 eggs. Or 480 eggs. So that's how I came up with about 400. Again, it depends. She might ovulate at 13. She might stop ovulating at 52. She might be on birth control. So an average is about 400, 400 to 500. Depends on, her lifestyle. Okay? Does that make sense? That's how I came up with 400. Questions about that? Okay. Now, the other question is, if you start off with 4 million eggs, then where did all the other ones go? All right. Basically, we've got to get the cream of the crop. Meaning, if I was going to plant carrots, and I want to get the best carrot so that I can eat it for Thanksgiving, right? I'm not just going to plant one carrot seed. Because what if that one goes bad? Or what if it sprouts and has like 2 things, like 2 roots coming out? It's not going to be the best. Maybe it will come out small. So it's not best to just grow one carrot. It's better to grow 100 carrots. Does that make sense? The problem is when you grow 100 carrots, or 1,000 carrots for that matter, they're not going to grow to full size because they're sharing the soil with every other carrot. They're sharing the sunlight and the rain, so therefore they're not going to have all the nutrients to grow to a big, full-size carrot. Does this make sense so far? Think of this as your eggs. Each month, thousands of eggs are going to start growing. You can't just let one grow, because what if it's a bad seed? No pun intended. But what if it's a bad seed? Not a good thing. So we're going to have about 1,000 or 10,000 or 20,000 eggs growing at the same time. Then after about 5-6 days, I don't know where this comes in. This is where there's a superior being or whatever, let's say God. He's going to walk around the garden, and after about 4 or 5 days, he sees them growing, and he says, you know what? I like that one. And that's the one that he or she is going to choose to grow, because this one's growing really nice. But what does he do with the rest of them? He stomps up. He kills them all, so that this one can grow with all the nutrients. It's already doing well so far. If you have other ones growing, it won't grow to the best ability. Sometimes God is indecisive. Let's say he's indecisive. He says, I like that one, and that one I like too. No problem. We're going to kill off all of them except for those two, and you could ovulate 2 eggs. And that's what causes fraternal twins. Because one sperm could fertilize that one, and another sperm could fertilize that one. All right, that's not identical twins. We'll talk about that another time, though. Okay? So that's what happens. And they do that every month. 10,000s and thousands of these eggs, they start growing, and then they all regress, and they all die except for one. You have 4 million. By the time you're 50 years old, they've used up all the eggs. So then the ovary just starts shriveling down. That's what happens. That's menopause. Because there's no more eggs to come out. Does that make sense? And as you get older, there's less eggs. Let's say, I'm just giving an example. Just giving out numbers. Let's say you're used to giving from, let's say, 13 to 35 years old, maybe 10,000 eggs are all growing. But once you reach 35 years old, now we've only got 9,000 eggs going to be growing. And as you get older and older, by the time you're 50 years old, there will only be, let's say, 40 eggs that are growing at the same time. So it's not a good big batch. That's why Down syndrome is more prominent in older women, because there's not much of a selection to go with. Does that make sense? Is this clear? And we use 35 as our magic number as AMA, advanced maternal age. So that at that point, if you're going to deliver by 35 years old, you're at a risk of having Down syndrome. So we would suggest if you want to do, let's say, a amniocentesis or whatever, to rule that out. Okay, but that's, if you've known about that, older women usually are more at risk. Doesn't mean they're going to. In fact, women who get more Down syndrome babies are women that are under 35 years old. Why? Because those are the women that are getting pregnant. We see more women under 35 years old that are getting pregnant. So there's a bigger batch. So of course there's going to be more trisomy or Down syndrome in that age. You don't have a lot of women after 35. I mean, nowadays I think there's a little bit more than what it was 20 years ago. I think 20 years ago they want to have a family and then start a career. Now I see the opposite happening. I think most women want to have a career and then have a family. And things are just changing that way. So I won't test you on that, but I just want to give you a heads up on that. All right. Any questions about where I came up with these numbers? The numbers you need to know and what's happening to them. Okay? All right. So let's talk about the ovarian follicles. Because there's different stages they go through. Okay? These are little sacs that hold the eggs, and they have different stages. Now, these sacs are actually cells that surround the egg, and when these cells are just very thin, almost squamous cells, very thin and only one layer, we call them follicular cells or follicle cells. When they have more than one layer, then we call them granulosa cells. Okay? So if you read in the book, you see follicle cells, granulosa cells. It's just telling you different stages, but it's basically the same thing. It's the cells that surround the egg. Okay? And these follicle cells and granulosa cells, they're going to release a hormone called estrogen that we'll talk about with the menstrual cycle later on. Okay? And the estrogen is there to nurture the eggs that are inside. So these are the different stages, and I'll show you a picture of this, of different types of follicles. There's one called the primordial follicle, and this is a very early on cell, or a very early on follicle. It has only one layer of cells around the egg and very thin. So they only have follicle cells around them. All right? So they're very thin, squamous-like. Gradually this gets older, right? Going through the cycle, and then it becomes a primary follicle. This is when we have 2 or more layers of cuboidal cells. Now they're not flattened, they're thicker. So now they're granulosa cells. Then it turns into a secondary follicle. Inside, between the egg itself and these granulosa cells, there's a fluid-filled area. And they start forming these, what we call vesicles. So many different fluid-filled areas around there. When you see those fluid-filled areas, then we refer to as a secondary follicle. But soon, those vesicles will fuse together, almost like on your table, you got a bubble here, a bubble here, a bubble here, you know, like beads of water. But when they intermesh with each other, they become one gigantic one. Does that make sense? So when these vesicles fuse with each other and become one gigantic vesicle, we then call the whole thing a mature or Graphian follicle. And inside we'll have one vesicle that now we refer to as an antrum. And this is really big and starts bulging out of the ovary. This is the one that God chose is going to erupt, ovulate, rupture. Once the egg pops out of the ovary, the area that it just popped out of is a crucial thing for you to know. It's now a new structure. It's called a corpus luteum. It becomes a glandular structure and it's going to produce more hormones. Oh, I know hormones. Reproduction has loads of hormones we'll have to go through. So this corpus luteum is formed once the egg pops out of there. It's that certain part of the ovary where the egg just popped out of, all right, or ruptured out of. And it stays there and it's going to release a certain amount of hormones for about almost a week. All right, about 6 or 7 days. It gets released, it releases these hormones, and if the egg gets fertilized during that time, the corpus luteum is going to continue to keep on doing that. It's going to release hormones. But in most cases, the egg doesn't get fertilized. So after about 6 days, 6 or 7 days, the corpus luteum dies and turns into a white scarred area known as a corpus albicans. Think of albino albicans. It's this white scarred area. And most of the ovary, when you become 50 years old, becomes a scarred tissue. Many of these corpus albicans, because that's usually what happens to them. You don't get pregnant every month. So most of them turn into corpus albicans. So here's the whole cycle. All right, you have primordial follicles. This is the whole ovary. Okay? So it's just showing you different stages. But you got to keep in mind, there's 4 million of these eggs in here. They're just showing you in the diagram here. So here's some primordial follicles, which is only one layer of thin cells around the egg. Then they start forming into these, once it has like 2 or more layers of cells around it, then we refer to it as a primary follicle. Then you'll see that there's some kind of fluid filled up inside here, this blue area here. But these are many vesicles that are filled with fluid, and they're in different areas here. Now this is known as a secondary follicle. When they start fusing with each other, all these vesicles, it becomes one gigantic vesicle known as an antrum. Now, and this is usually bulging out of here a little bit, now it's known as a Graphian or a mature follicle. This is the one that the egg is going to pop out of. Once the egg ruptures or ovulates out of here, then the area here is a crucial thing. It's now called the corpus luteum. Luteum means yellow, so it should be a yellow area. This picture's not really drawn to scale. This corpus luteum is going to produce and to release a lot of different hormones, which we'll talk about. For mostly estrogen and progesterone. It will stay growing and continue to produce estrogen and progesterone after 5 or 6 or 7 days if the egg was fertilized. If it's not, then this is going to die down and become a scarred area called a corpus albicans. Does that make sense? And you have this here. And you could just follow the whole thing going this way. Right? There's a corpus albicans, here's a corpus luteum, and so forth. Okay? This is showing the same thing what I just showed you. Primordial follicles, primary follicles, secondary follicles turning into our mature Ovarian follicle, the egg pops out, the area here is now called the corpus luteum. When it dies down, it now becomes the corpus albicans.
A primordial follicle consists of an oocyte surrounded by a single layer of squamous granulosa cells. A primordial follicle becomes a primary follicle as the granulosa cells become enlarged and cuboidal. The primary follicle enlarges, and the granulosa cells form more than one layer. The zona pellucida forms around the oocyte. The structure is called a secondary follicle when fluid-filled vesicles develop among the granulosa cells and a well-developed capsule, or theca, becomes apparent around the granulosa cells. The theca possesses internal and external layers. The structure is called a mature follicle when the fluid-filled vesicles form a single antrum. At full maturity, the oocyte is located in the cumulus mass. During ovulation, the oocyte is released from the follicle, along with some surrounding granulosa cells of the cumulus mass, called the corona radiata. Following ovulation, the granulosa cells divide rapidly and enlarge to form the yellow corpus luteum. When the corpus luteum degenerates, it forms the white corpus albicans.
So far, so good? All right? It'll make more sense when we start talking about the menstrual cycle, but at least you got the anatomy there. Okay. Just briefly about ovarian hormones. We're not going to the menstrual cycle, just some things about this. Estrogen. Estrogen, also called estradiol, which is a certain type of estrogen. That does female sexual characteristics, all right? Growth of endothelium, the endothelium. I'm sorry, the endometrium, okay? So estrogen is going to give the female sexual characteristics, all right, voluptuous body, okay, curves and stuff. It's also going to do the growth of the endometrium. So think about it. If we don't have estrogen, what's going to happen to the endometrium? It won't grow. It'll shed off. You see? We'll be talking about that. So decrease of estrogen may have something to do with why a woman menstruates. Okay? Progesterone. That comes from the corpus luteum after ovulation. So it's only going to appear after ovulation. And we continue to grow the endometrium if the ova gets fertilized. Okay? There's also going to be a little bit of androgens coming from the ovary. Testosterone. Okay? And that's what gives the woman the female libido, sex drive. Okay? So that's what the whole thing looks like. There's our uterus. The vagina's over here. Cervix would be this part. Here's your fallopian tubes. All right, fimbriae, ovaries. If we do a coronal cut here, see the whole Dodge Ram. So you get to see this. Okay? That's what it looks like before. That's what it looks like now. Okay? All right, that's what it kind of looks like too. The ovaries here are kind of big in this situation. She probably has something called polycystic ovarian syndrome, but won't answer that. But you can see the picture, right? Here's the cervix here. This is the uterus. Here's the fallopian tubes. The fimbriae over here. The ovaries over here. Pretty typical. Okay? And this is a sagittal cut. This. Well, let me take this off. It looks like that. When you get up closer, you'll be able to see it. Okay? Let me just show you on here. Again, belly button will be over here. Her bum-bum's over here, right? There's the sacrum. So here's the clitoris. Here's the pubic symphysis. Clitoris is here. Urethra is here. Vagina is here. Rectum's here. Anus, right? So there's our urinary bladder. What lies directly posterior to it is the uterus. The rectum is going to be found posterior to the uterus. Okay? Not too bad. This blue area is the abdominal cavity. You can see that if there's going to be some kind of infection from the cervix, like chlamydia or gonorrhea, it could ascend, go into the fallopian tube, and go easily into the abdominal cavity to set up camp at the liver. Okay? Questions on that? This is also a different perspective. If you're going to make an incision in the abdomen, and now you're looking down into the abdomen, so the feet are up here, the woman's head is down here. See how you're looking into it? Here's the intestines going down here, the rectum. This is going to be the uterus. The urinary bladder will be anterior to that. You can visualize that, like you're looking into the abdomen. If you're helping a surgeon or whatever, you get to see what that looks like. Okay? This is what I was trying to explain to you about with a bimanual examination. Okay? There's two hands that are going to be feeling for the size of the uterus if we have to assess that. We have to have two fingers that are going to be in the fornix. It's either you put it in the anterior fornix or posterior fornix, but you've got to have the other hand on the abdomen itself, and then where these two fingers are on your two hands, you could assess to see how thick or how big that uterus is. All right, in a large uterus, is it pregnancy? Is it fibroids, which we'll talk about later, or is it cancer? See what I'm saying? So that helps us to determine that. Now, some things about ligaments. All right? There's something called the broad ligament. We talked about briefly before. All right? This is just a connective tissue that's going to go over the fallopian tubes and the ovaries. But it's going to leave an opening between the ovary and fallopian tube so that the egg can actually find a way to get there. So it's not covering the opening of the fimbriae. Now we have true ligaments and false ligaments. The true ligaments contain blood vessels. So this is important for, let's say, surgeons, or if you're going to be, if you're going to assist a doctor with this. If you're going to cut through one of these true ligaments, you better make sure that you tie them before the blood goes out, right? So you need to know those. So these are the ones that contain the blood vessels in here. I'm not going to ask you too much about these over here. All right? You should just know the difference between a true ligament and a false ligament. The false ligament doesn't have any blood vessels, and that's going to be our round ligament over here. Okay? Don't get mixed up with the round ligament that we talked about with fetal circulation. Okay? This is the round ligament of the uterus. So what's happening over here is this. There's ligaments all on here. All right? There's the broad ligament that's going to go over the fallopian tube and the ovaries. Okay? Here's our round ligament here. Now, the best way I could explain with the round ligament, because I want you to know the round ligament. The best way I could explain it is so that the round ligament is there so that it doesn't go backwards or forwards. And I always show people is if you sit in a hammock, you know what a hammock is, right? You have this thing that's going to be tied to, these are my trees. So you have two trees and you have this little thing that you could actually lie down on, the little bed-like thing. Now if you sit in here, so you're actually sitting on here, if you're sitting on here and that thing swings, you're going to go back and forth. Does it make sense? Right? You're going to be doing that. So what the round ligament's going to do is if you put your hands down like this, that's what the round ligament's going to do. It's kind of holding you so you're not going to flop back and forth. And there's no blood vessels in here. All right? When surgeons need to cut that, they don't have to worry about that there's going to be blood vessels in there. All right? So they cut it over here, but you can see it would be going down. Right? It's this thing here, going down. Okay? We clear what a false and a true ligament is, right? Okay. Again, it's showing the same thing here. There's the round ligament going down. Okay? All right, just a couple things now about common conditions that you probably all heard about. Leiomyoma, all right? Lyo means smooth, and myo means muscle, and oma means tumor. So we're talking about a smooth muscle tumor. Fancy word for fibroid, okay? And I'm sure Obi's heard about fibroids. Fibroids, they're benign tumors of the myometrium. Remember what the myometrium is? It's the smooth muscle of the uterus. That's the ones that give you those nice, strong contractions. But it's benign, meaning that it won't spread to another organ. But it doesn't mean that it's not going to cause any problems. These are what fibroids look like. These big tumors over here. Some of them could be growing outside. There's the uterus here. Some of them could grow outside the uterus. Some of them might be just inside the uterus. Some of them might be in the cavity of the uterus. Most of them, 70%, are usually inside, something we call intramural. They're inside the muscle itself. But the sizes could be anything from the size of a pea to the size of a basketball. And depending on where they're growing and where they are on the uterus can cause some problems. For instance, you got a big fibroid on the back of your uterus, it could be pressing down on your rectum and could cause constipation. Or there could be another one growing on the anterior side and pressing on the urinary bladder and make you pee so often that it can cause incontinence. Does that make sense? All right? The ones that grow inside the intrauterine cavity are the ones that actually will cause more bleeding because you're increasing, there's that word again, surface area. So if this is going to be, I'm going to use this. So if this is your uterus, okay, there's our fallopian tubes, ovaries, right, and this is our vagina. So this is your endometrial lining. This is the part that's going to bleed during menstruations. But if we have a fibroid that's now going to enter the intrauterine cavity, well, we're putting a lot more endometrial lining on this. Does that make sense? We've increased the surface area of this place. So that means that this is going to bleed more because we have to get more endometrial lining off of the intrauterine cavity. Does that make sense? Okay? So that's what happens with this. So not all fibroids are going to cause bleeding. It's only the ones that are going to be inside the uterus. I mean, like inside the cavity itself. Okay? Most women have fibroids and they don't even know they have it. Most common presentation is what we call asymptomatic. They don't even know they have it. Okay? It's kind of an incidental finding that we'll find it on there. Or it might be just because they have a lot of bleeding. Now, the problem is, this is all muscular. The problem is also when they want to deliver a baby. If there's fibroids there and you want to deliver a baby, think what's going to happen. Normally, the uterus is able to contract and push a baby out like that. Contractions just go like this. But if there's a big tumor over here, then this is going to have much more of a strong push. So it's actually going to do this kind of push. It's not going to be in sync. And usually with women who have fibroid uteri and they're pregnant, they usually will have to go for a C-section because they're not going to be able to push the baby out because you need one strong contraction for all those contractions. Not 50% and then 50%. Does that make sense? Okay? The other thing I want you to know about fibroids is they feed off of one thing, estrogen. If you have somebody who has a fibroid uterus and there's a load of estrogen on there, these will grow bigger. During pregnancy, there's a lot more estrogen on board. So they're going to grow bigger during pregnancy. that make sense? Okay? But what happens when she goes through menopause at 50 years old? They're going to have less estrogen on their body. What happens to the fibroids? It goes away. There's no more estrogen. All right? So a lot of times we would say to a woman that, you know, you're 48 years old, you do have a fibroid over there. It's up to you. You know, we'll consider. We have to take it case by case. But if the bleeding is heavy, but not so heavy that she's, you know, leaving work early and she needs to take blood transfusions, I would ask her, you know, you're 48 years old. Can you live with this for the next couple of years because you're going to be going through menopause? Do you want to try, you know, if it gets bad, then we'll just remove the whole uterus. Because the only purpose for the uterus is to hold a baby. If you're 48 years old, I doubt very much you're thinking about getting pregnant. You know, today's day and age, you know, there's some doctors that are like saying, oh, we'll get you pregnant and stuff. But so that's what we usually will tend to tell them before doing surgery. The surgery, there's always risk with surgery. But if she's definitely like, she's adamant, I want it out, I'm just, it's very, well, you know, it's bothering her and she's bleeding a lot and it's affecting her daily well-being, then yeah, we'll remove it. Does that make sense? So again, fibroids grow because of the estrogen. It feeds off the estrogen. Hint. Okay? Questions about fibroids? Okay? All right. Pelvic inflammatory disease. What happens here is it's due to an infection, usually gonorrhea or chlamydia. And as I said to you before, let me just use the same picture but alter it a little bit. What happens here is that if there's chlamydia or gonorrhea that's over here, sexually transmitted disease, it can, and it's not treated, it can easily go into the uterus, go into the fallopian tubes, and come out and start causing problems outside into the abdominal pelvic cavity. What it does, it's going to also create adhesions. Adhesions is basically scar tissue. All right, think of putting gum in your hair and things just get all tied together and knotted, and they start causing mayhem around here. It can go on top of the fallopian tube, and like I showed you before, but pink up to where that area is. And now a sperm can't get into here because it's so tight, it's narrow. The egg can't get through here. So pelvic inflammatory disease, PID, can also cause infertility. It could cause pain because it's pulling on things. Massive pain. Okay? And that's what could happen with this. It's due to an infection, so you also get fever. All right? Questions about pelvic inflammatory? That's why we always want to treat women who's got, you know, gonorrhea or chlamydia so that they don't get this. Okay? Questions? All right, this is showing you pictures of what this adhesions would look like. Just a massive mess. This is one that I took when I was working. Just to get you oriented. Here's the uterus. Here's the fallopian tube. And all of this is adhesions, and it's being pulled. So we'd have to cut that and remove it. Okay?